Hello again, this is Amani Kittani, and we are gonna talk about models of disability and ethical issues related to the ICF. Traditionally, in many cultures around the world, people with physical, sensory, or mental impairments were thought of as under the spell of witchcraft, possessed by demons, or as sinners, being punished by God for wrongdoing by themselves or their parents. Currently, there are two models. First, the medical model of disability. For many years, the medical model drove assessment practices in healthcare service provisions, focusing on the diagnosis of a disease, disorder, or injury. The medical model of disability is a socio-political model by which illness or disability being the result of a physical condition as a part of individual's own body. It may reduce the individual quality of life and causes clear disadvantages to the individual. It is today specifically referred to as the medical model of disability because of the high degree to which medical solutions, such as surgeries and clinical physical therapy, are emphasized and how they are intended chiefly as a way to normalize persons' participation in society as much as possible. The medical model tend to believe that curing or at least managing illness or disability mostly or completely revolve around identifying the illness or disability from an in-depth clinical perspective, understanding it, and learning to control and alter its course. The medical model focuses on what a person cannot do. If the impairment, for example, then the disability is a wheelchair users cannot climb the stairs or walk to the shops. For example, a partially sighted person cannot read information in standard size print. A person with acquired brain injury cannot speak as quickly as other people. People with disabilities have generally rejected this model. They say it has led to their low self-esteem and developed life skills, poor education, and consequent high unemployment level. Oh, let me redo this one. Okay. 1, 2, 3. In this diagram of medical model, the medical model focuses on what a person cannot do. If the impairment, for example, then the disability gonna be, let's see. Like for example, if the impairment, let's redo it again. 1, 2, 3. In this diagram of medical model, the medical model focuses on what a person cannot do. For example, if the impairment is a wheelchair user, then the disability, that person cannot climb the stairs or walk to the shops. And if the impairment is a partially sighted person, then the disability that the person cannot read information in standard size print. And if the impairment a person with an acquired brain injury, then the disability is the person cannot speak as quickly as other people. People with disability have generally rejected this model. They say it has led to their low self-esteem and developed life skills, poor education, and consequent high unemployment levels. Above all, they have recognized that the medical model requires the breaking of natural relationships with their families, communities, and society as a whole. Since this medical or individual approach results in emotions such as fear of pity, Society has traditionally not recognized persons with disability needs as rights. Where their needs have been met, it has often been through charitable giving, reinforcing the ideas of people with disability as passive recipients. So in this picture you can see like how all the individuals and all the problem are into the individual and does not take any account for the social barrier. The ICD, International Classification of Population Health, began with a focus of the prevalence of medical diagnosis and causes of death with the Internationally Statistical Classification of Disease and Related Health Problem, which known as ICD. International Statistical Classification of Disease and Related Health Problem, 10th revision known as ICD-10, is a medical classification list for the coding of disease, signs and symptoms, abnormal findings, social circumstances, and external causes of injury or disease, as maintained by the World Health Organization, the WHO. The code set allows more than 14,000 different codes and permit the tracking of many new diagnoses. Using optional subclassifications, the codes can be expanded to over 16,000 codes. Using codes that are meant to be reported in a separate data field, the level of details that is reported by ICD can be further increased using a simplified multi-axle approach. So the ICD is a part of the medical model. The purpose of the ICD and of WHO, the sponsorship, is to promote international comparability in the collection, classification, processing, and the presentation of mortality statistics. New revisions of the ICD are implemented periodically so that the classification reflects advances in medical science. ICD allows for interactive information by using modern technology, integrates into health informatics systems worldwide, intended for daily clinical use with simple diagnostic criteria, and influences of psychosocial and environmental factors on disability. Other benefits are contributing to researches to better describe disease. ICD allows effective response to the need of health conditions, provides the legal and occupational purposes of disability, such as determine eligibility and accommodation. Limitations for ICD and the medical model. More and more, today the medical model is being rejected. Many people feel strongly that treating people with disability as needing to be adapted to existing circumstances, or if this is not possible, caring for them in specialized institutions is wrong. So some limitations for this model are: less attention has been given to social and environmental factors, less attention to the subjective and experiences of individuals with disability, and limited capacity for evaluating changes in the behavioral factors. Social model. The social model of disability sees the person with a disability, not the disabled person. Prevention of the person with a disability taking an active role in many day-to-day events and activities is the result of barriers imposed by society. Such barriers are often inaccessible buildings and service, as well as inaccessible transport such as trains, buses, and taxis. It is the responsibility of society to adapt to meet those needs in the same way society has adapted to meet the needs of people without disabilities in areas such as getting from A to B on public transport to be able to undertake their work commitments, or a lift to the 18th floor to assist when carrying their normal day-to-day workload. Those people above are not pitied, they are merely assisted. People with disabilities are not looking for pity. They are simply seeking the same assistance from society to be able to achieve as near as possible the same results. People with Disability Movement believes the cure to the problem of disability lies in the restructuring the society, unlike medically based cures that focus on individuals and their impairment. This is an achievable goal and to the benefit of everyone. This approach suggests that people with disabilities and collective disadvantage is due to a complex form of institutional discrimination. Let me do this one again. 1, 2, 3, go. Look at this slide. People with Disability Movement believes the cure to the problem of disability lies in the restructuring of society, unlike medically based cures that focus on individuals and their impairment. This is an achievable goal and to the benefit of everyone. This approach suggests that disabled people's individual and collective disadvantages is due to a complex form of institutional discrimination. The social model focuses on ridding society of barriers rather than relying on curing people who have impairments. In this picture here, you can visualize that the disability is not located inside the person, but reflects the social and environmental barrier. Limitations for the social model. First, it could not measure disability, so you could not figure out who is person with disability or not, and it could not distinguish who qualifies as a person with disabilities for services, like to determine the eligibility in the public services. You have to have a you need a medical model to determine that. And no empirical testable researches in this area are available. Here, the biopsychosocial model, which is known as the ICF. The ICF adapts a biopsychosocial model of disability that incorporates what is true and useful in both models and rejects what is counterproductive and distorted. Disability, as in ICF, is a complex phenomenon that includes both a dimension at the level of person's body and a dimension that is a complex and primarily social phenomenon. Medical and rehabilitative interventions are perfectly relevant to the body level aspects of disability. And by the same token, environmental and social interventions are relevant to deal with restrictions in persons' participation in educational, economic, social, cultural, and political activities. For producers and users of disability statistics, the use of the biopsychosocial model embedded in the ICF broadens the perspective of disability and allows medical, individual, social, and environmental influences on functioning and disability to be examined. Furthermore, advocates of both models can use the ICF as a platform for communication and choosing and comparing intervention. People with disabilities face many myths, stereotypes, and assumptions. These barriers are built into society and can be very detrimental to the success of those with disability. Disability is just different. It is nothing bad. People with disabilities do the same things others do. They just might do it differently. The offer table discusses the disability-related paradigm shifts. So you can look at this schedule, for example, or for this table. The disability is, in the medical model, you can see the disability is abnormality, while it's in the social political model, its disability is difference. And being disabled is negative, with the other model having a disability is neutral. Another thing, disability resides in the individual. With the new model, disability derives from the interaction between the individual and society. And go on. The provisions to the ICF address 3 general areas: respect and confidentiality, clinical use of the ICF, and social use of the ICF information. And we are going to talk about each of these individually on the following slides. Respect and confidentiality in ICF. The primary responsibility of counselors is to respect the dignity and to promote the welfare of a client. Counselors respect the right of clients to make decisions on their own behalf, on decisions that may limit the autonomy of a client. Counselors and the client work jointly in devising and revising integrated, individual, and mutually agreed upon rehabilitation and counseling plans that offer a responsible promise of success and are consistent with the abilities and circumstances of a client. About the informed consent, rehabilitation counselors recognize that clients have the freedom to choose whether to enter into or remain in a rehabilitation counseling relationship. Rehabilitation counselors respect the rights of clients to participate in ongoing rehabilitation counseling planning and to make decisions to refuse any services or changes in the services, while also ensuring that clients are advised of the consequences of such refusal. Rehabilitation counselors recognize that clients need information to make an informed decision regarding services and that professional disclosure is required for informed consent to be an ongoing part of the rehabilitation counseling process. Rehabilitation counselors appropriately document discussions of disclosure and informed consent throughout the rehabilitation counseling relationship. The clinical use of ICF. In a clinical use of the ICF, 3 methods should be considered or taken. First, the clinician should explain the purpose of using the ICF to the individuals. Second, giving them the opportunity to participate in this assessment. And use the physical and social approach in a holistic perspective. For the third aspect, which is the social use of ICF information, ICF information should be used with the collaboration of individuals to enhance their choices in decision-making process and ultimate product. Also, the ICF is used toward the development of social policy and political changes to support the individuals, and all those information derived from its use to benefit individuals or a group. ICF involves individualized perspective, which each person is unique and different. More issues to talk about, and these are ethical issues. First, Kitchener's ethical principles, social justice, mental health parity, bioethics. And we are going to talk about each one of these issues. Kitchener's ethical principles. First, non-malfeasance is defined as not causing harm to others, potential areas of harm, wrong services provided, misuse of assessment result, and undeveloped plan are not carefully monitored. Oh, let me start with this one again. Okay. Okay. Kitchener's ethical principles. First, non-malfeasance is defined as not causing harm to others. Potential areas of harm as wrong service provided, misuse of assessment results, or developed plans are not carefully monitored. Second, beneficence. The quality or state of doing or producing good. This is the foundation of the rehabilitation counseling process or any professional relationship in the disability field. Third, autonomy. Autonomy is the quality or state of being self-governing, self-directing, freedom and especially moral independence, and a balance between autonomy and doing what is perceived to be best for the client is required and should be taken into consideration. Fourth, fidelity is the quality or state of being faithful, accuracy in details. This principle includes confidentiality and informed consent, keeping promises. Finally, justice refers to equal access and equal treatment. Regarding to Patterson in expressing justice aspect, he mentioned that believing in the dignity and worth of all individuals with disabilities, rehabilitation counselors must guard against discriminating on the basis of a client's disability, ethnicity, gender, or personality. Limited resources also influence justice in rehabilitation when counselor must decide who is most needy or whether to expand more on one client and less on other clients. The Mental Health Parity Act, and it's known as MHPA, signed into law on September 1996. This law requires that annual or lifetime dollar limits on mental health benefits be no lower than any such dollar limits for medical and surgical benefits offered by a group health plan or health insurance issuer offering coverage in connection with a group health plan. The law generally requires parity of mental health benefits with medical surgical benefit with respect to the application of aggregate lifetime and annual dollar limits under a group health plan, provides that employers retain discretion regarding the extent and scope of mental health benefits offered to workers and their families, including cost sharing, limit on numbers of visits or days of coverage, and requirements relating to medical necessity. Regarding social justice, first, advocacy by using the ICF to facilitate the empowerment and inclusion of persons with disability in society. And it includes also the inclusion, which is included people with disability in important decision-making process. Another dimension is environmental task force, in consideration the influence of interactions between individuals and environment. Now we will talk about the last ethical issues, which is called the bioethics. Bioethics is the study of controversial ethics brought about by advances in biology and medicine. Bioethics are concerned with the ethical questions that arise in the relationships among life sciences, biotechnology, medicine, politics, laws, and philosophy. It also includes the study of the more commonplace questions of value, the ethics of the ordinary, which arise in primary care and other branches of medicine. Bioethics did not get enough attention to the study of issues related to disability, and most of its focus was on acute care model of healthcare, such as sick or dying patients. A focus on the health services that affect where people with disabilities live is very crucial. Examples of these services that we need more look. Let me start with this one. Okay, 1, 2, 3. Okay, 1, 2, 3. Go. A focus on the health services that affect where people with disabilities live is very crucial. Examples of these services are rehabilitation care, long-term care, and home care. Questions. Why bioethics? Do we really need this kind of science? Yes, it's one of the moral safeguards for patients or individuals with disability. It provides us with tools out of seeming impasses and cultural divides and make better healthcare providers and moral thinkers. What would bioethics offer to the field of disability and rehabilitation? There are like 2 domains it may help with. First, emphasizes and more disability-friendly treatment and research environment, and contributes to the philosophical analysis of the right-based approach that has dominated public disability advocacy. Limited number of researches about social factors is available. A grant funding is usually available for the study of technological issues rather than social barriers. Bioethics have not paid enough attention to ethical issues relating to chronically ill, control the abilities or disabilities of those who will be born, and pediatrics issues. Here are some examples to think about, and I hope that we will discuss most of them on the blackboard. The first case is about the long-term care right. A 22-year-old man with cerebral palsy and liver transplantation 10 years ago, using wheelchair and unable to communicate, living on a tube feeding now. Recently, he started developing slowly progressive chronic kidney disease and expected to progress to end-stage kidney disease that will indicate need for dialysis in the next few months. What would you suggest to his family? Are you gonna suggest comfort care, or continue medicine but no dialysis, or continue everything plus the dialysis? Another case we can discuss about is end of life decision. An elderly man who is dependent on the respirator and lives in a long-term medical facility used to communicate with his family and staff by nodding his head. Recently developed a stroke and became unable to communicate with other people. What would you recommend for his family? Withdraw care and end of his life, or continue all medical treatments? Kind of hard cases and hard decision to make. Another case. If you, your sister, or a client found out that the fetus will be born with a disability, what would be your recommendation? Should they seek abortion? If yes, why? If not, why? Another case. 32-year-old female with end-stage lung cancer with a spread to liver, brain and bone. She lives 24 hours, 7 days with pain in multiple body area. Her jawbones, shoulders, hand, back, legs. She takes multiple pain medication that has caused side effects like constipation and decreased level of consciousness. She describes her life as, "I have no life. My life is very painful and disgusting." What are you going to do for this lady? Are you going to advise her to do euthanasia or not? Continue her life or stop it? And this is another case about the surrogate pregnancy. A young couple could not have a baby because the wife had advanced heart failure and the doctors advised her not to get pregnant. They went through surrogate mother, but the surrogate mother refused to give up the baby at birth. What do you think in these cases? Who deserves the baby? The biological mother or the surrogate mother? With all these examples and the situations with the advance in medicines and technology, many ethical issues raised, and this is the need for bioethics came from. Please pick one of these cases and let's discuss your opinion regarding to these cases. I am sure a conflict will be raised up, but that's fine. Recommendations about the bioethics. Bioethics should concern itself with the full range of theoretical and practical issues related to disability. And the bioethics should develop the right to healthcare and the right to community integration. Bioethics must assist in the public's understanding of disability in the life cycle. And bioethics should aid in understanding and reform of research and treatment related to disability. I will continue with this one. And bioethics should aid in understanding and reform of research and treatment related to disability. And finally, bioethics and more researches in this area is needed to protect these vulnerable individuals' rights. And again, thanks for your listening.